minutes to share what you just explored, to let us know. We hear scope was a conversation, what's in scope, what's out of scope, what needs to be clarified. And then in each of your sections, what are those points that really needed modification or improvement for this document to inform those of us who are going to continue this work? Now remember, this isn't the end. We're back at it tomorrow, so don't, for your bedtime reading, look at the information for tomorrow's discussion too, just to facilitate our time together. All right? We hope to be done by 4:45, but as Dr. Cole says, if we're going strong, we may go longer. All right? Right, boss? No, we're going to have a party at 6 o'clock. Yeah, all right. I've got the timer up here. My students are used to that. Where is group 1? Or shall we start with this corner of the room? Thank you. And please come. Oh, do you want me to give her a microphone, Dan, or you want to be our microphone person? Thank you. Starting the timer when he gets there. Did you have fun doing this? Was it interesting? Could you hear the presentations from this morning resonating as information in your head as you thought through these points? I know we did. To all the presenters, great job. Are you ready?
Sure.
Thank you.
So I volunteered to scribe for our group 1. My name is Amanda. I'm actually a pharmacist by background, so thank you all for letting me join you today to hear this conversation. I am here to share our thoughts. We had a really robust discussion about the scope. We talked a lot about how kind of the conversation that happened around does this apply to all these areas? How do we make it broad enough, narrow enough at the same time? Thinking about that kind of common checklist like you would use on an airplane where everybody has a checklist. They can't take off without calling the tower. There are certain things they have to do, but recognizing that each plane is different and therefore you might have different specific checklist items based on that. So we started with that as our scope discussion, which actually helped us level set and get through the topics around paragraph 1. We agreed with all of the content in paragraph 1. When we got to paragraph 2, we had a lot of discussion about why are we calling out specific disciplines? If you call them out, that's fine, but if you don't call out the dentist as an example, they may say, well, this doesn't apply to me because I wasn't included. So we had a lot of discussion back and forth, and we actually landed on striking the entire second paragraph as our recommendation. And then for the third paragraph, we had a lot of discussion as well, again, kind of talking about the difference between providing anesthetic care and sedation care as well as administering, and then that led us down the path of adding some additional language there and actually removing disciplines, because the concern about if you're calling out physicians and nurses, who are we forgetting? Or who are we unintentionally saying that this doesn't apply to you? So we landed on the specific language of these recommendations apply to personnel providing, administering, supervising, or monitoring procedural sedation and anesthesia care in non-OR locations. These recommendations are intended to supplement existing guidelines/recommendations addressing similar clinical scenarios. So we actually, on that second sentence, actually excluded, I think it said supersede, that supersede statement. We actually suggested to pull that out for the purposes of the fact that there may be other guidelines that are out there that may not be in congruence with this, and we wanted it to, again, kind of the patient safety as the North Star, wanted to make sure that that was in there. Then we started to talk about facilities. We didn't make it really far, quite honestly. So anybody from Group 1 have other things to add? Other comments? Okay, thank you.
You definitely did a lot of work in the scope. Thank you so much. If you would send your electronic information to Stacy, that would be awesome. Thank you. Yeah, bravo. Next group. Where are you?
Group 2.
Okay.
Okay. So we started our discussion by going over how we would define the scope of NORA. And essentially, it boils down to we have office-based procedures and then non-operating room procedures at the hospital, which we listed out a number of them. And we had some discussion about whether or not we should include obstetrical anesthesia in there, and we decided that that would be excluded. So essentially, we ended up with, you take out traditional operating room, ambulatory surgery center, and OB, and really any other areas where anesthesia-based services are being provided is how we defined the scope. And then we ran through the facility points and did have a couple recommendations. On the fourth bullet point, we suggested changing volatile agents to inhalational agents, just a word change, and then I think Jeff had some comments about nitrous oxide. Are we gonna, do we want to make that part of our recommendation? Sure.
Well, the debate, there was no mention at all about nitrous oxide, and if people are going to use these guidelines when they're faced with having to plan a NORA service, we thought it maybe made sense to put a comment in there. I was advocating for nitrous oxide as neither required nor recommended because of the environmental impact of the drug, but adding recommended didn't seem to go down as well. Apparently people aren't as green as I thought. But, but anyway, nitrous oxide is not required, might be a useful addition as a guidance for people that are using these to plan NORA services.
Thanks. And then on bullet point number 7, we were going to add without leaving the immediate care area, just to make it clear that we're not leaving the patient. And then on point 8, adding continuous before suction. Thank you. Next, we ran through the recommendations with regard to equipment. We had some discussion about equipment and in the context of both patient safety as well as clinician safety. Identifying the needs, making sure that all the providers in the room are appropriately trained, and if new equipment's introduced, then everybody has that training, particularly when we're going to new parts of the hospital. Next recommendation that we had was on bullet point number 3, and again, making note that equipment should be accessible. Then on point number 5, having medications stored in Pyxis. I think that's it. That's okay. Then on bullet point number 7, we had some discussion about the MH cart, and there was some conversation about whether or not this was potentially conflicting with some of the other organizations. Samba, yep. So we want to make sure that the guidelines are consistent with the other recommendations that are out there. So in some of the office-based settings, depending on the types of agents that are being used, rather than having an MH cart being available, just a statement that there's a plan in place to address any MH crisis. Yeah, right, the phone, yeah. Then we had some discussion about omitting point number 8 under there, with the EEG and consult by an expert, is whether that would be practical in all practice environments and settings, thinking about areas outside of the hospital, maybe office-based procedures where that's not practical. So the attorneys on our, Brian and I didn't want these to be put under your nose by plaintiff's attorney someday, wondering why you didn't have the cardiologist readily available to do the read for you during the case. And then with number 10, we suggested adding consider to that. And I'm sorry, what was number 11? Do we have? Okay. Okay, yeah, adding consider to number 11, sorry. I think that's it. Okay. Yep. Thank you.
Wow. Very excellent work.
Good job.
All in all, let's go back to the scope with that group. Did you feel like what you gave us as recommendations were within the scope that was identified in defining what the NORA locations are? And if that's a trick question, you can skip it.
No, I think that what you're asking is, do we agree that Nora locations are in hospital or office-based? Is that what you're asking us?
Yep.
And that's what the group agreed to, correct?
And that all of our recommendations would work in the office setting or they're scalable for both? Yes. Okay, all right. Thank you for confirming that. Nice work. Group 3.
Hi, Tim Dowd. I'm a anesthesiologist trained in pediatric anesthesia and also in critical care. And the green room was home to a very spirited discussion of the various options. Starting with scope and paragraph 1, there was some discussion around concern that we were a little overreaching, that we would go beyond what we would likely to be able to achieve. But in the end, the consensus was that we should go big. And if what we're all about is safety, then we should be going for the most possible safety. And so we kept paragraph 1 intact. We deleted paragraph 2. We were concerned, what were we concerned about? We were concerned about the list of all of the people, and we didn't see a point to it, and so we thought it was it would create potential offense. We didn't want to do that, and so we wanted to avoid 2. We left 3 basically intact. On equipment, we were quite concerned that we were being a little parochial by naming anesthesiologists or anesthesia personnel as the determiners, and so we recommend strongly that we replace anesthesia personnel with all stakeholders. And we thought broadly about all stakeholders without any particular, this is in no particular order of importance, but I think we wrote IT, proceduralists, anesthesia, nursing, environmental folks, pharmacy, but anyone who is going to be involved in managing that room and designing it would be named as stakeholders. In 2, again, we had the same concern, and so we used stakeholders again as our rather than replaced anesthesia personnel with stakeholders. Oxygen supply was an interesting discussion as well. We think it's impractical to insist on a central oxygen supply, but we think it should be encouraged that central oxygen supply be available, and that even with central oxygen supply is available, there should be backup oxygen supply for each procedural location. Where they're using volatile anesthetics, we think that there should be some scavenging system for the safety of everybody involved. It's just not sound to have those gases just being inhaled by all the staff. In a summary of an old colleague, when we talked about electrical supply, he said, we should have all the electricity we need and backup for when it breaks. And I thought that was a pretty good summary of what our position should be. On lighting, should be lots of light. All the light that's required should be available, and that there needs to be a backup supply of light, as we've all been in a situation where the light disappeared. And that backup has to include things like flashlights, because it needs to be separate from the rest of the electrical system. I missed in the electrical system that there needs to be a backup supply for that electrical system. Generators should be encouraged, but battery backup at the very least. And there needs to be sufficient space for all the equipment that needs to go into the room. And one of the things that I thought was brought up that was quite insightful was not just the equipment that's required to do the procedure, but when things go bad, how do you get a crash cart in the room? How do you bring the cavalry to the to the rescue, and so we added that as part of our recommendation. And we're not parochial in suction. We think there should obviously be adequate suction for the anesthesiologist, but I've heard that endoscopists and other folks also use suction in the room, and so there should be suction available to make the procedure safe. And we didn't get beyond that because of the spirited nature of our discussion, so that's where we had that. Anybody else want to add anything? Yeah, please.
Mention the point on some of our electronic equipment is very susceptible to power fluctuations, and in the radiology suites we've had some of the fancy computers there that they use for imaging go into a reset mode. When the power blinked on and off, the generator kicked in, they really need to be on a uninterruptible power supply so that won't happen, because if you've just shot the contrast and done the spin around the head, you don't want to have to redo that during an aneurysm coiling.
Anybody else? Comment? Dr. Cole?
Thank you so much. And again, send your thoughts to Stacy so we have them.
Second.
I got the notes here from group number 4. We definitely spent a lot of time discussing the scope. To summarize, our group's concern was that if office-based and non-hospital procedures are included in the scope, we lose the ability to have the specifics that really gain weight with these statements. If we're talking about NORA in hospital, it's an issue because it's not the same as an OR, and that's what a lot of the in-hospital people are wanting to be able to achieve with their administrators. They're looking for these recommendations to hold some weight, and if we dilute them out to make them applicable to office-based anesthesia, as we've already done with like the equipment listing where it says if clinically appropriate, if you think it's needed, if possible. When you sort of muddy those waters, then it's easier for admin to turn around and say, well, we don't think it's necessary. We don't think it's appropriate. And to really have the strong statements where our group would recommend that the conference and outcomes recommendations really apply to in-hospital NORA, and then we use those recommendations to build appropriate separate recommendations for the out-of-hospital and office-based settings. So that they
a
can,
separate document.
yes, so that they could also carry strong recommendations that are applicable to those sites.
Did you talk about dental?
Yeah, we talked about how dental really needs some guidance, but that if we just put out a document like this, where we're trying to encompass both in-hospital and dental all in one, and everything becomes, if your site dictates it, it really leaves them an out to just say, well, we don't need, it doesn't apply to us. This says if it applies, and we say it doesn't apply. So having two separate documents and really specifying that location and then having the appropriate recommendations for it could carry a lot more weight. One of our group members specifically pointed out that if we set out a kind of recommendations where it's pick and choose, then the adherence level is going to go down. So it kind of loses the punch to it. Subsequent to that, we pointed out some of the numbers in the facilities where we thought some things needed to be looked at. In number 4, talking about volatile anesthetics and scavenging. Again, if we're going to be in an office system, active system's not always possible. It says capture system. We weren't sure if that was the same as like a passive system. Just looking for some clarification there. Talking about electric outlets, maybe putting in specifications that they're at an appropriate level to avoid cord trippings. In a lot of newer facilities, all the outlets are being put at waist level, which is great when you're plugging in a wheeled monitor, but it's not great when the monitor needs to be more than a foot away from the wall, because now you're creating trip lines throughout the room. So putting in stuff like some mentions about that, like cord management. And number 7, talking about specific space, also not just space for the equipment, but also to provide clearance from the equipment for the people who are there, so that there's not just we could shove everything in this room, but but everything's in the room and there's enough space in between it for the healthcare team not to get whacked in the head with various things. And number 8, talking about suction, defining what an operating room standard is of suction, maybe just saying that it's sufficient for the needs. We also wanted to add a few things to facility along the lines of electric outlets, that there's also enough data ports or Wi-Fi capability sufficient for anesthesia equipment. You know, a lot of anesthesia machines and like Pyxis machines require in-wall data ports or Wi-Fi to do the functions, and if we really want to standardize them to meet the OR standards, then we need to have that IT availability there too. We had a team member bring up kind of needing a mechanism for outlining when a procedure needs to be abandoned and like at what point the procedures can be stopped for the safety of a patient, either because there's not the right equipment there, there's not the right personnel there, or the patient just isn't tolerating it. Then we didn't get much time to talk about the equipment stuff because we spent a lot talking about scope, but it basically boiled down to what we said about scope, that if we aren't going to include office-based settings, we can be a lot more stern or precise in the wording of the equipment that should be there. And if we are going to include all those far-flung places, we need to have the qualifiers that really say, if appropriate for the setting, if appropriate for the patient, and kind of give that wiggle room. Our group did also want to add, though, to the equipment a statement similar to the one about MH for having MH rescue, but specific to having intralipid rescue at places where high dose and local anesthetic would be used. So, and there's already some guidelines on that from NYSOR or ASRA that we could just make sure that they're referenced in there as necessary rescue equipment. So.
Wow, thank you for
And I
that
think that was
thorough
it
review
for
of the
4.
work. We're very grateful. I know I have more questions for you, but I think it'll unfold as we listen to the other groups. There may be some closing questions for all of you. Bravo.
Are you group 5?
So, my name is Girish Joshi. I'm going to speak on behalf of our Group 5. Same as other groups, we had lively discussion on the scope. I think that's the most controversial part of this whole document. And same as Group 4, we also were toiling on whether it should be just in-hospital practice versus out-of-hospital practice. So overall, though there was no consensus, the discussions were that we should first define NORA in-hospital, which would be obviously, outpatients versus inpatients because their patient selection may be different. And out-of-hospital would be the ambulatory facilities, the so-called Class B facilities, where sedation is done, GI facilities, and the OBA practice as well as dental practice, which is part of OBA. Dental practice basically is OBA. And we emphasize that we need to really define this before we move on to further recommendations. Also, there's the statement which has been made providing anesthesia care or sedation. We really don't need or sedation or anything like that, so just anesthesia care. The second paragraph in the scope, same as one of the groups, we basically said that's not necessary, and we could really define based on what I just presented. There was some discussion on the recommendations applied to anesthesia personnel and non-anesthesia personnel. Once we say non-anesthesia personnel, it becomes very difficult. How are we going to implement that? And we had some talk about how ASA recommends or enteral CO2 is a standard for us, while the GI groups, their societies said no way in hell. So though it's not standard and we mandate it, how can we implement this or impose on so-called non-anesthesia personnel? At least there is anesthesia care being provided, we should have our recommendations. Our discussion on the facility part of it, we have some minor edits, which we have in here rather than going into details. They're basically wordsmithing. But we do want to recommend to add a 9th bullet point for the facility part, and which would state that pre-procedural and post-procedural care areas should be identified and equipped and staffed appropriately. So we recommend that. Our discussion for regards to equipment was a little hurried, and again, lack of time. Nevertheless, bullet points 7 to 11 were similar to group 4. We also wondered whether these were, consider this and consider that, and they're more site-specific. So these bullet points really need to be either excluded or reworded appropriately. For example, there was the bullet point which stated, I think 11, locations where blah, blah, blah is done. So location-specific recommendations. Anything else I'm missing from our group? Oh, so the other important aspect we discussed is with regards to the process of developing guidelines, we should collate all the guidelines from different societies, ours and non-anesthesia societies, and go through them and see what's applicable to our APSF recommendations, and then have one overarching recommendation. So example, what we consider as standards. That would be, doesn't matter where it is, whether it's in a hospital, OBA, or in Class B facilities, the standards are standards. So there should be one overarching and then more specific aspects. Anything else? Yeah, so I mentioned the anesthesia services rather than specific type of anesthesia, sedation or analgesia or deep sedation and all that kind of, just anesthesia services. Yes. So we got almost everything. And then, yes, I will give this to Stacy because we have wordsmith a few of the recommendations. Thank you.
Thank you so much. You are all staying on time. This is just, and providing so much information as well. Group 5, where's Dr. Cole?
So that was group 5. I'm bringing up the rear with, or was
Are we
that group
5 or 6?
We're 6. We're the virtual group. I think we're the last one.
Is that it? Did we do 5?
Did 5 go?
Oh, all right.
Yeah, that was 5. All right, so my name's Megan Lanefall. I have the pleasure of serving as APSF Vice President. Thank you all for coming. We had a small but mighty virtual group. So we assumed a broad scope, but ran into some of the same hiccups that you all described. We keyed in on the importance of language that a lot of you mentioned, and so we thought it would actually be useful just to have a terminology section or a glossary to say, this is anesthesia personnel, this is equipment, this is NORA, so that we could deal with some of these issues. We also thought that we should add a qualification that these are minimum recommendations and that there might need to be additional steps taken depending on patient comorbidities and specifics of the procedure and the location. With respect to facilities, we keyed in on number 2. So we thought that the recommendation about grouping NORA suites together or near the OR really applied to either new construction or renovation, and so we just added that caveat there. Going down to equipment, number 2, a lot of you mentioned equipment standards. We thought that the standard should be tailored to the level of sedation administered, so that if you're shooting for or you're actually achieving light versus moderate versus deep sedation or GA, that the equipment should actually track with that. For number 5, we wanted to change adequate to appropriate, understanding that there's some wiggle in how people define these terms. And number 6, about emergency carts, we wanted to add that emergency drugs should include reversal agents for opioids and benzos if those are administered. And then we got slowed down also with numbers 7 through 11. We wanted to reject number 8 about EKGs because we thought if the scope is really, really broad, that's going to be difficult to operationalize, thinking especially of dental settings. And then we got hung up on infusion pumps too. Are they smart infusion pumps? Are they not? Do you need infusion pumps? So I think we all kind of keyed in on the need to really spend some time with those particular recommendations. But I think those were the high points.
Thanks, Megan. With time to spare, I think we probably have a few other questions we might have of the audience and just to set the stage for tomorrow. But the other thing I was thinking about as you were all talking, we're talking about Pyxis units and we're talking about a lot of equipment that may not be in all hospital settings even. How do we level set this to be usable across? And if a hospital is a hospital and an office-based setting is an office-based setting, something more to discuss tomorrow. The dental office discussion was pretty lively in the group that Megan and I facilitated online as well. And I'm not sure we really got to the bottom of that as we work through our groups today. And I'm not sure how we'll decide to manage that going forward. But since we do have just a few minutes, is there anyone who would like to add more thinking around how we could influence dental practice? Go ahead. No, I'll bring you the microphone. Or come on up. Oh, here comes Patty. There you go.
I can comment on the dental thing, but I wanted to just touch, before we left equipment, there was one thing that in our group we were kind of short on time with equipment, but that wasn't listed, was sequential compression devices. I feel like if it's a case of appropriate length, typically over an hour, I think those need to be included in cases. So I think I would like to add that to the list, please. Okay. And dental. I think it needs to be included with office-based. I don't think we need to separate it out from the office. So I think they are an office and they need to have the same standards and it shouldn't be separated. And I don't think it should be any different between the dentist and the GYN, the urology, wherever else we are providing office-based anesthesia.
Thank you. All right, JW, you want to wrap us up for today?
Yeah, thank
Lynn,
you,
1
Lynn.
second, Lynn.
Oh, there's more.
Oh, go ahead.
Excellent. Hi, Angie.
I just wanted to add, we kind of started to talk about it a little bit at the end, but I wonder if there should be a statement to touch on what Dr. Ribello spoke about today, which is the drug side of things, either standardizing labels, ready to administer drug delivery, making it more safe for the drug delivery part of it.
Thank you for that reminder of who we are. More?
Yeah. So question for a couple groups. Groups 4 and 5, 4 made it very clear about their concern about too broad of a scope and what we could accomplish if we're trying to cover all of these areas with one set of recommendations. There were some other groups that said, let's go big. Let's go for something overarching, a bit more on what Rita had talked about earlier today, about wanting to create recommendations that address a large number of practitioners and a large number of sites. From groups, I guess it was 1, 2, and 3, was there discussion in those groups about how effective it would be to take a broad scope rather than narrowing it to hospital-based NORA, for example? Did anyone in any of those groups be able to summarize a discussion if it took place?
I can summarize ours. We went back and forth, and there was a difference in opinion, and we ended up voting, and the majority was to go big. And then even for the part of the second paragraph being removed as well, we had a discussion and then voted, and that's how we came about. But there was that discussion that occurred.
JW, I agree. 3 was the same way. There was, again, a very spirited discussion about it.
You want to get the one up on the podium?
It actually was a complete consensus vote where everyone said yes to going big. But I don't think there would have been any objection in the group to have any clarifying statements about what going big meant, and if somebody wanted to list all of the various anesthesia potential sites, just for clarity purposes, there wouldn't have been an objection, I don't believe, to that. Yeah.
Thank you.
I mean, I think, you know, going big is great, but I think we also have to consider the resource-limited environments that we live, not only in the United States but beyond. And so I think we have to figure out what's achievable and realistic, you know, and measurable too. So, you know, obviously, if we had all the technology and all the money and all the experts in the world at our fingertips, that might help. But is that realistic in all these different environments and workplaces? And I think some of us, you know, who work in very big institutions with a lot more resources might be exposed to that regularity of care, but that might be achievable in certain areas, but not others. So I think we really need to be conscious of what can be achievable on a much larger scope.
So we can go big, as our group also didn't have a consensus about exactly the same thing. We can go big, but we can have two separate documents. It's still going big. It's just not being specific in one particular document.
Yeah, so ultimately we want these recommendations to be impactful for patients and clinicians globally. Where's the harm taking place now? So I know this, I did not take thorough notes this morning. Where are patients being harmed in these locations? Is it in the hospitals, in neuro locations, or is it in outpatient settings? And does that help us target what we're doing during this conference? And then also, is there a middle road, not just going hospital-based NORA? There's also procedural centers outside of the hospital, and then there's offices. So do we say hospitals plus procedural centers, or all three? Any comments about, first, I think, where's the harm taking place, and then second, which of these facilities?
So I think it's great that you bring up this notion of harm, because our mission statement is that no one shall be harmed by anesthesia care. And following the mission statement, I think that suggests that we should go big, personally. In terms of where the harm is, I don't have the statistics at my fingertips, but you know, what's going to be the impact of what we're going to revisit this now? We're going to put out whatever we put out there, and we're going to move on to other things. So people are going to take what we publish, and that's their ammunition. So, and I think I would like to see us empower the people going into the offices. I think it's easier in the hospitals to have the dialogue. It's easier in the procedure centers. It's very hard in the offices to set a standard and get it enforced. And so I think that's probably one of the biggest impacts we can have, is empowering those people. And maybe we just be careful with the words we use. So consider doesn't put a legal cloud over their heads, but it also makes it clear what we think the standards are. So I would advocate for going big from that purpose and empowering those people going into the offices.
Yeah, Jeff, I agree. I was in group 4, and we were the group, I guess the first comment of maybe there is something different for a purely office-based setting versus a NORA in the hospital. And in my mind, it's a sensitivity and specificity sort of decision. How sweeping and broad are our go big recommendations, but in order to make them applicable to our colleagues in a pure office-based setting, they're somewhat nebulous enough to allow some of that flexibility that they then really are not anything other than some words on a piece of paper that don't have a lot of meaning to a purchasing officer or the surgeon and their colleagues that own the practice, where we're trying to get this, that, or the other thing. And so to me, it's almost like an ACLS algorithm. There's some overarching principles that apply regardless. And then there's sort of a decision tree piece. If you're in an outpatient ambulatory surgery center, that may be, or a freestanding cath lab, that may be a little different than the pure office-based procedure room versus the
in the hospital IR suite that's right down the hall from the OR. And I think we can do one document that accomplishes all of that, being able to make much more specific recommendations in each category, as opposed to, well, on Thursdays, if it's a full moon, you might want to consider the possibility of, but only if it's good today. I mean, that's not very helpful, in my humble opinion.
So first, I'm going to apologize to Group 1 because they heard me talk way too much because I don't shut up. So I'm Tom, by the way. I'm the CEO of Quad ASF. So we are a standard-setting body, right? So we accredit outpatient centers and ASCs. That's what we do. So we're used to writing standards like this, and we've been messing with them and revising them for 40 years. So what I would say to this is I don't think it's a binary. I don't think it's go big or narrow in. I think it's actually, there's an approach that you could do that we're doing now that is write the standards, apply them where they're applicable without using words like consider, because that's the other thing I would caution against, because everybody considers everything, right? And especially when you get to recalcitrant facilities that are doing the bare minimum, it's really easy to write a policy, yeah, we consider this when it's not applicable, right? So to me, and one of the things that we did, I'd also caution you not to produce different documents. The minute you start producing different documents, even with the best laid plans, you will start editing those documents year after year, and they will slowly diverge. And you'll wind up in 10 years having completely different requirements. So to me, and what we've done is we basically took all of our standards and put them in one pile and then created a matrix, right? So absolutely, we want you to do X. Now look and see if it applies in the office, in the hospital, NORA, in the ASC's procedure, in the freestanding procedure place. So if we have 1,200 standards, that some subset of them apply across every single setting that we accredit. You need board certification in the specialty that you're providing care. You need to honor AMA Core Principle 7. Those are standards that we hold really near and dear, and they're core standards for us. And it doesn't matter what setting you're in, those apply, right? But then things like using a sink, you're allowed to have a sink in the procedure room in a gastro suite. You're not in an open surgical environment. It doesn't mean we have different manuals for that. We used to, but they became a nightmare. So now it's sort of a matrix rather than a decision tree of saying, on a binary basis, am I fish or fowl? And if I'm fowl, I have to follow these rules. And if I'm fish, I have to follow these rules. And so I think there's a way that this organization and this sort of body of recommendations can sort of go big while still narrowing in on each individual setting, whether it's the dentist or the office. And the other thing I would say is, and this is not blowing smoke at the room and reading the room, this is actually the most impactful group that there is in medicine, right, to me. So we've been making conscious strides to deal with anesthesia providers because you are the only group that is in every specialty setting, right? If we deal with gastro, we deal with gastro. If we deal with urology, we deal with urology. If we deal with anesthesia, we deal with gastro, urology, plastic surgery, orthopedics. We deal with everybody. And so whatever you set really has the ability to change medicine across the country and really around the world. So I think taking time to make it a conscious effort to go big while focusing in on those environments can really make a dramatic impact.
Thank you. One follow-up question from me about language used as a qualifier. So there are standards, like monitoring standards, and then there are things that we think are a good idea, or that maybe you all think are a good idea. If we don't use the word consider as a qualifier, would you say recommend? Would it be, what would be the approach of your organization if there's something similar?
So I think there's a difference between consider or make a judgment, right? An informed judgment that shows a process, and do it if indicated. I think those are slightly different, right? And part of that's an attempt to say, if you can put it near the OR, do it. Well, that's possible in the hospital, but in a freestanding environment, that's not really possible. So instead, carve that one out, put that in the different level, in the different column of the matrix, and say this applies in the hospital, not necessarily in the freestanding environment, because you can't put it near the OR because there isn't an OR in that interventional suite or whatever it is. So I think that's where I would say you get away from the sort of foggy language. Where you want to force people to make an informed medical decision, I think we've done that a lot. And we do have things like consider, your leadership should make a decision on, and they should be able to document that, right? When we say, what drugs do you have on the emergency cart, they should be able to show well, here is our discussion, here is our minutes of our meeting as a leadership group, even if it's a solo practitioner. I got my nurse, I got my administrator, and myself, and we sat down and we said, here's our patient population, here's the services we provide, and here's the resuscitative equipment we need based on that. So at least they're documenting a thought process and not just a knee-jerk reaction, or, well, this is how I did it at a center 20 years ago.
Thank you.
Thank you.
Hi. I have to echo what Dr. Feldman had talked about. What you heard this morning about the office-based and dental community. First of all, reality, whatever we come up with today is going to have a great impact on preventing harm. You saw Dr. Agarwal talk about the deaths in the dental office. And you also heard what we said was right now there's 33 states that have legislation. That means there are 17 states in the United States today where anyone can do anything and get away with it. So and there's no recording of adverse events. So if I were making a recommendation from this meeting, if we wanted to have the greatest impact, the fact is, I can't change the government, we can't change the government to make uniform legislation. I rewrote the guidelines for Massachusetts, and we updated it in 2022. But if you look right now, you will look and it will show you that 17 states have no legislation. So my ask from this group right here, right now, is that we do something that would prevent, as Dr. Feldman said, preventing harm in this arena. And you also heard me say that the mobile anesthesia groups that are going out, and I have my colleagues here from the East, my colleagues here from the Midwest, and I told you about Philip Yen in San Francisco, and they're booked until 2024. So the fact is, people are doing pediatric dental cases, which is office-based anesthesia. And the fact is, there's a lack of legislation. So my request for this group is, if we do something right now, without changing the government, and as you say, what I've heard, that this is, Tom said this is a powerful group, and we have effect on everybody, well, and as my colleague said, let's go big. Well, I think that the onus upon us is to do something about this group immediately. Thank you.
Thank you.
Awesome. I just have a really brief comment. Am I next? Anyways, so I am previously from a very rural state of Iowa where there's 117 hospitals and more than 80% of them are critical access, where they have 25 beds or less, and most of those beds are like skilled nursing type beds. So people are doing like one surgical procedure a day maybe, and then possibly going up to like radiology for something. So I'm just hoping that we can make these standards based on the lowest common denominator. We want to make sure that hospitals that are this tiny can achieve these standards for us. And like, if we want to add like special things, that's great, but it has to be something that everybody can achieve reasonably.
I don't know who said it this morning, but what's staggering to me is the mortality rate in Nora is at least as much as it is in the OR ×1. I mean, 0.4 mortality rate and 0.2 in a hospital-based OR, and more to come on our outpatient flip from inpatient. And I think that we have an opportunity here to set the standard and then watch the payers and the malpractice carriers and the regulators make change. And we're way behind in this. I've been in this business long enough. I remember before we did timeouts, and it wasn't until the regulators sort of mandated it, you don't get paid unless you have these standards, and you're not accredited and you're not licensed. So we need to we're behind. We need to quickly do this. So applause to everybody who seems to be on board with that.
Agreed. Thank you for the comment.
I just wanted to say, I think where we don't want to use the word consider. Elsewhere in the document, we've used if clinically indicated. And I think, that's something we can talk about specifically for the whole, equipment section.
Yep.
I see the language in this has already been crafted a little differently than it was originally in the survey that makes it a little more possible for office stuff. And if that's what we want to do is have this broad statement, again, I think what we're losing by doing that is we have to basically have every one of these with a qualifier, and I think that qualifier can be if clinically indicated. And you can, kind of apply that to all the things, the different kind of equipment, and it brings up what Tom said, where it sort of makes you have to have that discussion. And I think we should say if clinically indicated by the patient condition and by the procedure being done.
Yeah.
Because even in hospital, Nora, there's a huge difference between a GI patient who's just failed previous sedation having a screening colon versus a 6-hour EMR and GI versus a neuroradiology for stroke protocol. So all of these need to take into account patient condition and the specific procedure being done. And I think we all want to support anesthesiologists to make clinical decisions, and when they're doing sedation, moderate sedation without an anesthesiologist, you have to be able to make clinical decisions, but having this support of the things that you need to think about, options you should have, I think that's great. I do think that if we want this really to be impactful, though, to the dental groups as well, another big advocate who's actually on our side, anesthesia side, is the American Society for Dental Anesthesiologists, and I don't know that any of them are represented here. But we've had some really great members from that group sit on our OBA committee for SAMBA. They are also very committed, to following the ASA guidelines, to being the voice for safety in the dental office, and I think having them part of the discussion and moving forward with this would be really great too.
Thank you for those comments.
You just used the word that I think is the word to use here rather than the other modifying words that you could use, and that's guidelines. They're weaker than standards, but they are much more powerful than some of the consider language, or a word like guideline has tremendous power. You have the option to not do it, but you better be real careful when you don't do it, because you better have an explanation for why you didn't do it. And for me, whose funeral do you want to go to? The stuff that you see today, Caleb, that's a heart-breaking kind of thing that I don't want to be part of a profession that says, well, that happens, because it shouldn't. And everybody that heard the way that child was treated said, boy, there's nobody here that would behave in that way towards that patient. Every kid in the United States and every kid in the world, but start small, and every kid in the United States at least should have that sort of standard of care. And that's the word you use, guidelines. This is what we do, this is what we recommend, because we like birthdays, we don't like funerals. And that's the approach we should take.
Any additional comments on the please.
Bobby Jean Schweitzer. So Megan, I'm going to respectfully disagree with you in using the term if clinically indicated. I think that's just another way of saying consider. I think that's what, every dental office, or most dental offices that I have seen be involved in adverse outcomes, say of why they didn't use end-tidal CO2 monitoring. That the tubing was too expensive, the machine was broken, the patient is X, Y, or Z. And I don't think anesthesiologists always make the best decisions. In fact, I think that's we have a lot of data that some of these adverse events, I mean, you just highlighted a lot of the dental stuff, but it's not always the dentists that are getting us patients into trouble. A lot of anesthesiologists. And I think that, the ASA doesn't say use entitled CO2 or consider entitled CO2, right? It says use it.
Yep.
So I think that's where it's not easy, and I agree that, in small institutions, it's like, but the standard of care in the United States has been defined across the entire United States, right? It doesn't matter if you're in a tertiary care, quaternary care, center in downtown Chicago, or if you're in Oklahoma, if you can afford to put a medical institution there, if you're regulated by, the medical establishment, the patient should not suffer because they just happen to live somewhere. Or they happen to go to somebody who chooses and says, well, it's not clinically indicated to monitor your entitled CO2 when I give you propofol, ketamine, on and on.
But then would you suggest that we just strike the whole equipment section that says arterial blood pressure monitoring, ultrasound at every facility, and instead just put out the guidelines to cover every location, but just get rid of all those things that aren't appropriate for every location?
I think you do as Tom said. You have a matrix, and you say, if you're going to be doing cases, X lifts, where you expect blood loss, and you've typed and screened the patient for 6 units of blood, you better have a way to monitor hemoglobin levels. And I've literally seen those kind of cases done electively, where they had no way of monitoring hemoglobin levels. Well, how are you going to, why are you, having 6 units of blood available if you can't even monitor the hemoglobin level? So I think you write those kinds of, just like the ASA decided that for moderate to deep sedation is when you need entitled CO2, right? So it's not easy to do necessarily, but I think it's doable. And I think you do have to be very specific in guiding people to do the right thing and making it hard for them to do the wrong thing.
Thank you.
Okay. Thank you. I have a question for the group. In the effort of going big, considering what happened with COVID, should infection prevention somehow mentioned? For example, sometimes one of my concerns is the turnover in some GI places in which they have an occupancy by the minute. Do anesthesia providers or personnel have the time to clean up the station and guarantee that minimize the risk of cross-contamination?
Yeah, we don't have that currently in the draft, but I do believe we could find a spot for that.
Absolutely right. JW,
excellent point.
If I could make one comment about guidelines and standards. Typically, the Anesthesia Patient Safety Foundation has not been a guideline producing or standard of care producing organization. We've been sort of a consensus recommendation, and they are different. The guidelines and standards are usually typically taken up by national parent organizations and have been associated with a rigorous evidence-based literature review, which is an actual substantial process that requires an extensive amount of human and financial resources. However, we are a very nimble organization, and we're able to get out ahead of all these guidelines and standards to try to move the needle. And so that's what we're doing here. All of you are here because you're multidisciplinary, multi-professional stakeholders that care about making safer for patients and providers areas in and outside of the hospital. So we typically have been trailblazers in that fact across the last 35 years because we've been able to get ahead of a lot of the rigmarole and slow action of guidelines and standards that have to go through all of those specific steps. So when we talk about guidelines, I just want to be clear on that. And standards, that is not what we're actually doing at this conference. I just want to make that very, very clear. That doesn't mean that what we do at this conference is not, in many ways, equally, if not more important. because again, we are a large voice. You know, we are an international organization that speaks to a lot of anesthesia professionals and a lot of people and patients around the world. So we can get ahead of things and try to move the needle, and we've done that in several ways to influence our national organizations to then go ahead and produce the guidelines and standards and practice advisories that we see on a variety of different levels. So I just want to make that comment because I'm hearing we got to push and go big on guidelines. Yes, but that is not what we're doing here. We are making consensus recommendations to try to move practices in what we think is the right direction. So I just want to make that clear. Thank you.
Thank you, Steve.
So when I hear about this, it's really, we are trying to reinvent the definitions. The definitions of standards, guidelines, consensus statements, advisories, and position statements has already been published in ANSYS Analgesia a couple of years ago and accepted by all the journals now. So we really don't need to reinvent all this. And whatever we come up with, we can retrospectively define it based on the definitions already accepted by not just ANSYS Analgesia, even anesthesiology, etc. Because anytime you go to publish these things, we are going to look at those. So I was the first author of that document, and we don't need to reinvent the definitions again.
Thank you for adding that. Any additional comments? It's been a full day. All right, well, I consider our last bit of discussion here really insightful, really productive. And Dan, you have some comments here to close us out for the day?
Two sentences. 6 o'clock out by the fountain where the cars let people off. We'll have a reception barring an imminent thunderstorm, but I don't see one on the horizon. And then we reconvene tomorrow at 7:30. Thank you, everybody, for a great day.